Good evening. I want to welcome everybody to this week's Sagis Diagnostics Dermpath Happy Hour. We're pleased to have Dr. Allison Messer hosting tonight's section. Dr. Messer is a dermatology-trained dermatopathologist who currently is on the dermatology faculty at the University of Texas Health Science Center in San Antonio. Dr. Messer completed her dermatology residency in Houston and subsequently did a dermatopathology fellowship there. She's an excellent teacher, and tonight is going to be discussing a potpourri of dermatopathology cases. As always, if you have any questions, please feel free to submit them to education@sagisdx.com, and one of us will get back in touch with you. And with that, I'll go ahead and turn the floor over to Dr. Messer. Allison?
All right. Hi, everybody. My name is Allison Messer. Thank you for joining me this evening for the next Sagis Dermpath Happy Hour. We're just going to go over about 10 cases that I've seen in the past year or so. It's kind of my first year out as a dermatopathologist, just to kind of get a flavor of what's out there. All righty. So here's our first case. Let me just get it to where everyone can see a little bit easier. So we have a punch biopsy here. And what we're seeing so far is you can see there's a very dense, superficial and deep dermal infiltrate of some very blue appearing cells. So this immediately makes me think of the 5Ls differential. So basically, cells that look like this are usually very densely packed lymphocytes. So the differential might include a lymphoma or a pseudolymphoma. Lupus erythematosus can have a superficial and deep lymphocytic infiltrate. Polymorphous light eruption occasionally can have that as well, though usually a little more papillary dermal edema. And then one of the other L's that's included is LUS, or an older name for syphilis, because we all know syphilis can look like anything. Some people include the lymphocytic infiltrate of Jesner on that 5Ls list as well. I kind of lump it in with the lupus since it's kind of borderline if that's its own entity or not. That's controversial. So anyways, we'll have to go on a little bit and kind of see how these lymphocytes are arranged and what's going on here. Already you can kind of tell it's very dense and honestly a little concerning for lymphoma. You can see even some of these areas over here, germinal centers are starting to be formed. But always a good idea to have a good close look at your infiltrate. And while we're doing that, we kind of see that there's a foreign body here. And this is actually these are tick parts. So, and all of this eosinophilic material is sometimes referred to as tick cement. That's just kind of the immune system trying to wall off these tick parts, because as you can see, the immune system is not happy with this tick being embedded into this patient. So as we kind of look around a little more, you can see, yes, there are quite a few lymphocytes, all those really dark blue, high nuclear to cytoplasm cells. But you can also see there's a lot of eosinophils, a ton actually sprinkled throughout. And here you see more of that kind of eosinophilic material that was seen over here trying to wall off the tick part. So good news, this was actually just a pseudolymphomatous reaction to a tick bite. The patient had a large nodule in their leg that was present for like 6 months after having seen a tick and removing it. We gave the patient doxycycline just to be sure that no spirochete infections were transmitted. And with the punch to excise the retained tick parts, the patient's nodule improved and they were much happier. So no further workup needed with all the heme path stains for this one. All right, so moving on to the next case, we'll go ahead and rotate this one as well. As you can see, we've got another punch biopsy here. This one, just from scan, has a very squared off appearance, which, you know, a lot of times we talk about with the morphea or scleroderma or other scar-like conditions. However, it's important to note that sometimes these infiltrative conditions can also kind of pack in between all the spaces between the collagen bundles and also create a squared off appearance for the punch biopsy to also think about when you're scanning through. So already, even at this power, we can see that there are a lot of blue dots in here. There's some sort of cell kind of infiltrating through the collagen here. So there are benign conditions that can do this. Sometimes, at scan, maybe a dermatofibroma where there's a lot of fibrohistiocytic type cells going through the collagen bundles could potentially look this, or even maybe a interstitial granulomannulary. But once we kind of get a little closer, we see that, these cells are kind of large and atypical and making these, linear cords, or what we call sometimes single filing through the dermis here. And if we can get a little bit closer, you can see that there's, a lot of pleomorphism between the nuclei, and usually this type of infiltration with this many cells is typically malignant, especially when you can start to see the cytology and a few mitoses here and there. So this ended up being metastatic breast cancer. This came from the breast of a patient that had known breast cancer. Sometimes the single filing appearance has been associated with lobular breast cancer, which sometimes can be bilateral and important, especially for a new diagnosis to perhaps mention. However, this patient just had invasive ductal carcinoma, and that's how this was presenting with this single filing pattern. There are a couple other entities in the skin that sometimes single file. You guys probably know the glomus tumor. So that's one thing to consider. However, that's a benign tumor. And then also congenital nevi, congenital melanocytic nevi, can sometimes have the melanocytes kind of single filing through the collagen bundles as well. So we'll move on to the next case. So here we have a shave biopsy. And let's go ahead and rotate. So at this power, we can kind of see that there may be something going on with the epidermis here, kind of going along the whole span of the epidermis. You see some clear cells kind of infiltrating. So we would sometimes, when we see cells that aren't supposed to be in the dermis, these clear cells in the epidermis, we call that pagetoid cells. And there are a couple of common causes of, seeing pagetoid cells in the epidermis. Most commonly, or most famously named as for Paget's disease, which can be kind of related to our other case. It's a cutaneous manifestation of underlying breast cancer. However, we now know that there is also extramammary Paget's disease. So sometimes that could be a GU or a GI malignancy that has spread to the skin. And then there's also kind of this nebulous just Paget's disease extramammary that is thought to be skin primary, and kind of controversial, the origin of those cells. So Paget's disease, another common cause of pagetoid cells in the epidermis is melanoma, and squamous cell carcinoma is another cause. There are many, many causes. Sebaceous carcinoma, some consider mycosis fungoides to be a cause, but the Paget's disease, melanoma, and squamous cell carcinoma are usually the most common. So kind of once we figure out our differential, we go down and look and see, okay, like what kind of cells are causing the problem here. And in this case, this biopsy came from the groin of a gentleman that had a chief complaint of hematuria. So this ended up being Paget's disease, or extramammary Paget's disease. So far, the patient has not been found to have an underlying malignancy, but we did do immunostains just to confirm. We checked some, cytokeratin staining to see if the pattern is consistent with Paget's rather than, squamous cell carcinoma. And then a lot of times we'll do a SOX10 or an S100 just to make sure that this isn't a melanoma. Another helpful clue sometimes is getting kind of high power and taking a look and seeing if you can find keratinocyte spines around the atypical Paget cells. If you find spines, that's a better clue that it could be squamous cell carcinoma. And if you're not finding the spines, then that might be more indicative of a Paget's disease or a melanoma. Location can help, but sometimes immunostains are needed to just be 100% sure. All right, so next case, we have a shave biopsy, a little neoplastic entity. You can tell this was kind of a papular nodule sticking up off the skin. Location hard to tell for sure here, but based on the architecture, it appears to be benign. You can kind of bisect it in half and it kind of looks the same. And if you need to go higher power to take a look at the cytology, we're not seeing a whole bunch of the atypia, and what we're really seeing is there's a lot of clear cells. And you can see that it's kind of sharply demarcated on this side and this side from its border, which are often also, reassuring architectural features of being benign. So basically we have a thickened or acanthotic growth of clear cells. And then a very helpful clue is number one, this came from the leg, which is a common area for these to be. And then we see that there's kind of some neutrophil crust on top of this. So this was a clear cell acanthoma, usually red nodules or papules that happen on the leg. Not super commonly seen, but we see them once in a while. I kind of think of them as if psoriasis had a neoplasm, then that's what it would be, just given the acanthosis and the neutrophils that you can see on top. But the clear cells are helpful. Other things in this differential that have clear cells, sometimes we see squamous cell carcinoma with clear cell change. We can see irritated seborrheic keratoses or clonal seborrheic keratoses that sometimes can get clear cell changes as well. We'll also see soon another tumor entity that can have clear cells. And then, one other thing to consider, maybe if you're on test taking purposes, is to consider mucosal areas. Frequently have pale cells as compared to the other areas of the skin. Alrighty, so speaking of clear cells, we kind of have some more paler looking cells here. We've got another neoplasm. This time we're seeing some really enlarged sebaceous glands and hair follicles. So most common, we see these types of things on the head or neck, occasionally upper trunk if you're an oily person, but this happened to be on the nose. You can see there's also a thickened growth. There's some epidermal acanthosis here. Not a whole lot of cytologic atypia going on, fairly well circumscribed, just like our last tumor. But this one, and we can see as compared to the edge here, we see a little bit of pale cells, compared to this more normal epidermis on the sides. But another thing that we're kind of seeing here is this palisading of the basal nuclei here. So this is a trichilemmoma, benign hair follicle tumor, frequently seen in association with Cowden syndrome, also frequently tested fact. However, we don't always, just see them in Cowden syndrome. If it's just an isolated trichilemmoma on one person, that can just be totally normal variant. And frequently they're sent in kind of as warty appearing growths on the head or neck area. So just something to consider on your kind of clear cell differential along with the clear cell or pale cell acanthoma that we just saw. All right, just going to rotate this one. So you can see that we have a polypoid growth or a pedunculated lesion. And there's a nice clue in there for you. This stuff here, this is some nice healthy cartilage. So nice healthy cartilage and kind of this pedunculated lesion where we see a lot of vellus hairs. This is an accessory tragus. Sometimes they just put these on the exams for instant pattern recognition. A lot of times they're not going to give you the nice piece that has the piece of cartilage. But the teaching point here is to recognize these tiny little baby vellus hairs and recognize that that could be, something from a baby. This was a young baby that had an accessory tragus that was removed. However, even in adults, we see these tiny vellus hairs on the face, commonly lateral face, sometimes on the eyelid near the eyebrows, even the ears or parts of the neck. And then in a cyst condition, sometimes we see these vellus hairs as well. That's in the vellus hair cyst, but the architecture would look a lot different in that case. Alrighty. So here we have a shape biopsy. Can already tell at this power that we're kind of missing part of our epidermis, partially ulcerated and eroded. Location, a little bit hard to tell. We can definitely see we're somewhere with hair follicles, but not too much jumping out. So go a little higher power. Seems to be something disrupted in the epidermis here. And what we're seeing here is acantholysis. So many causes of acantholysis of the epidermis. So that's basically when our desmosome spines are given up and falling apart, and you kind of get these rounded up cells that we're seeing here. Most commonly, we usually see changes like this, maybe in an acantholytic actinic keratosis or an acantholytic squamous cell carcinoma. Other benign entities sometimes that we see this in is the warty disc keratoma, which is not super commonly seen. Some people might biopsy a little papule of the Grover's disease, and you can see the acanthosis. If you have a more widespread rash, consider the pemphigus or Haley-Haley disease or Darier disease. But this is a little bit different than all those. We don't want to forget our infectious causes. So I've been staring at this for a little bit, and what you can see is these steel gray nuclei, these really pale blue nuclei is a hint for this condition. We can see down here, there's more of these nuclei that are kind of becoming multinucleated. The nuclei are molding together, and unfortunately a little hard to see here, but on some of these nuclei, we see the chromatin marginating around to the edge. So these are kind of all the 3M signs of herpes virus infection. This actually came to me as just a rule out basal cell from the scalp. So it was a surprise case of herpes, but we, just because it was a little strange, got the immunostains and it was confirmed to be herpes simplex 1 virus. So don't forget about your infectious causes of acantholysis. You'll have to put that on the test. Alrighty. So here we have a kind of a small punch biopsy. So far, not much sticking out too much. At this point, I try to maybe go off the location, which here is not super helpful either, but we kind of know we're not acral, we know we're not mucosal, we don't have very, very thick stratum corneum, and we still have a cornifying layer. We don't see a lot of, deeply seated hair follicles, so probably not the scalp or head or neck, not a lot of sebaceous glands. That kind of leaves us maybe trunk, extremity type area. And really the main thing going on here is, there's a little bit of perivascular, superficial perivascular lymphocytic dermatitis, which, is a pretty non-specific finding. Sometimes with cases like these, it's kind of like a partially treated rash, or you have to start going down your normal skin differential, which I like to kind of go from top to bottom, like things that you might be able to find in the stratum corneum, such as tinea or candida, things that you might find in the epidermis, such as changes in the granular layer that might be related to an ichthyosis, or stuff that's going on the basal layer, looking for changes in your melanocytes, vitiligo. Sometimes in the dermis, you might see your change. You might see some amyloid, few extra eosinophils for urticaria. And then a very rare entity that we don't see a lot with some dilated blood vessels and some increased mast cells is the T-MET. So if you guys didn't catch it already, we're kind of checking in right here. We've got a sandwich sign. So we've got this basket weave orthokeratosis kind of overlying this compact orthokeratosis. Not a lot of parakeratosis going on, but this is considered the sandwich sign, where you kind of have alternating layers of different types of keratosis or orthokeratosis or parakeratosis. And in here you can see a lot of fungal hyphae. Here's one here, and they're kind of all scattered in right here, right between that sandwich, making the meat of the sandwich. And if you don't believe me, I will show you the PAS stain just to prove it. A lot of times tinea corporis is a little bit hard to find on the H&E, which is why you'll probably see your Dermpath checking PAS so often. But here you go, here are little fungal hyphae getting highlighted with the PAS stain. You can kind of see here they're septated, okay, and they also kind of have these pale hollow tube centers. So that's really good for tinea corporis. Alrighty, our next case here, we have got a shave biopsy, seeing some sebaceous glands here, so good clue for head and neck. Sometimes proximal, trunk or extremity, but more commonly head and neck. And we see that we have a neoplasm right here, we call it decapitated. They got the top of it, but didn't let us see the whole thing. But otherwise, even though we can't see the whole thing, it's kind of small, pretty well circumscribed. We can tell at least where the top of it kind of starts and stops. And inside, we see that we've got some spindle cells. And our spindle cells are kind of going all different directions. We have some of them kind of arranged longitudinally. And then over here, we kind of have a fascicle that's transversely cut. So when we see these spindle cells, the question is, what are the spindle cells? And most commonly, the spindle cells will be either fibrous, they could be muscular in origin, or nerve. So those are the most common origins. But we always say there's other. Other melanoma can always be on the list. It's kind of like the tuberculosis. It can always be TB, or it can always be things like HIV are always there. So in dermatology and dermpath, never forget about melanoma because it can look like anything. So it can have spindle cells. Other things that can have spindle cells not included in our original list, keratinocytes. So the spindle cell squame variant. And then the last thing I always think of kind of in the back of my mind on my big long list is endothelial cells, because we know Kaposi sarcoma can have spindle cells, and some variants of the angiosarcoma can actually be spindled. So remember your three most common: fibrous, muscle, or nerve, but also remember kind of the other list of more rare bird things that could do this. So here, looking at these, we kind of see that these are kind of delicate nuclei. Some of them are a little bit wavy, kind of see that bubblegum pink appearance that we see in neural tumors. So this ended up being a palisaded encapsulated neuroma. Other names for it nowadays are the solitary circumscribed neuroma. Basically, I just think of these as like tiny little versions of a schwannoma. Very common on the head or neck is where they usually occur. And they're usually a lot kind of smaller and superficial than your schwannoma. But otherwise, they kind of have that appearance. And here is our last case for this evening. This one's a little hard and requires some clinical correlation. We didn't get the best biopsy specimen, but this is more of a rare entity. So basically what's happening here on this bottom piece is this is actually a subepidermal blister. So this is our epidermis that is turning pink. A lot of times pink or red is sometimes what people call it. Red equals dead. This is epidermis that has kind of died and separated off. And it's kind of hard to see because this is such a superficial biopsy. We don't see much of the underlying dermis. So you just have to take my word, it's a subepidermal blistering disorder. Cell poor, there's not a lot of cells within our blister cavity except for erythrocytes. So these were hemorrhagic bullae, in this case on the back of the hand. So some of other clues on this piece, you get a little bit better. You see a little more of your dermis. You can see some really, really dilated blood vessels with very, very, very thickened walls and a lot of solar elastosis here in the background. So cell poor blisters with prominent vessels with thickened walls. This ended up being Porphyria, cutanea, tarda. In this area, we might see a few of the little, quote, caterpillar bodies, which are kind of hard to tell if that's just all dying, skin that has separated, or if those caterpillar bodies are really in there. But this patient ended up having porphyrin testing. Serum porphyrins were elevated, so good clinical correlation here. If you didn't have that good correlation, you kind of have to think of your other cell poor blistering disorders, which a lot of times we think of the epidermolysis bullosa. PCT, Porphyria, cutanea, tarda is on our list. Other entities that are sometimes biopsied are the coma blisters, edema bullae, or the bullous diabeticorum. And I just like to add to the list, sometimes we see cell poor bullous pemphigoid. That's a more common blistering disorder we see, and occasionally people have already been started on prednisone or systemic steroids, and sometimes we don't see as many cells as we would like, as many eosinophils as we like to see. So I kind of also put that on the list. But that's it for our cases. And if you guys have any questions, please feel free to contact Dr. Davis and he can pass them along to me. And y'all have a great rest of your year. Thanks.